All right, so this is our overview of our whole cycle here. So you're breathing stuff in. What do you breathe in? Oxygen. So our next section will be oxygen, but we'll take a break after this slide. All right, so you're breathing in oxygen. So let's breathe in here. All right, so it's breathing in oxygen. Oxygen comes in to your alveoli, right? Makes its way all the way down. It accumulates. The oxygen will accumulate in the alveolus, and there's such thing as a dead space of air in your lungs. Because how do you know how much air you're breathing in of oxygen? It's about 21%, right? 21% is room air, right? How do we get that? Well, all of atmosphere, depending on where you are in the Antelope Valley or Venice Beach, it's going to be a certain percentage of atmospheric pressure, right? Oxygen is always 21% of atmospheric pressure, right? So at the beach, it's 760, right? So 21% of 760 is 150, right? And that will make its way into the lungs. And that will make our PO2 all the way at the base of the lungs, the alveolus, about 100, right? So we have 100 to work with in our alveolus. What if we don't breathe in? What if we are what? Hypoventilating, right? You're hypoventilating, you're not getting rid of CO2, but you're also not bringing in O2, right? So if you're hypoventilating, you can also be hypoxic, right? You can also have that PO2 level in the base of the lungs is going to start to go down and down and down, right? But eventually, everything in the universe goes where? Goes from high to low, right? And our alveolar capillaries were ready, right? They're delivering all the CO2 from the body and delivering all blood that it has a lot of oxygen, a little bit of oxygen. Our cells use oxygen, so the blood going to the lungs should be low in oxygen or high in oxygen? Low in oxygen, right? So what side of the heart pumps blood to the lungs? The right side of the heart, right? The right ventricle pumps all that deoxygenated blood to the lungs to get oxygenated, right? And how does it get oxygenated? Is there some kind of protein carrier or something like that? No, it just dissolves across the alveolus, through the alveolar wall, through the interstitial space, through the capillary wall into the bloodstream. And it doesn't dissolve well in the bloodstream, right? 3% of it does get transported as PO2, but 97% of it needs to get picked up by our hemoglobin, right? But this is the PO2 that's actually dissolved in the bloodstream because our hemoglobin will pick up some of that stuff as well. All right, so our PO2 is 40 after the cells used all that oxygen, it took all the oxygen, then now your veins have deoxygenated blood, and it goes from 100 to 40, right, high to low. And then our CO2 goes from high to low. Our CO2 is higher in our venous system because who made CO2? Our cells down there, our tissues in the green triangle, right? Our tissues made CO2, and that then is going to get transferred to the lungs, and our lungs will then blow off the CO2. What if we don't blow off the CO2? It's going to stay at about 47. You keep now blowing off the CO2, now it's 50, 55, 60, 65, 80, 120. All right, the CO2 can go up really, really quick if you're not breathing, okay? So that's the whole purpose of the alveolus. What if you have a pneumonia? You got a little gunk in there. That's going to make it difficult to get oxygen in, right? It's also going to make it difficult to get CO2 out, but it depends what's going to happen first. Usually the oxygen is going to start causing a problem, right? And what if we have a pulmonary edema, right? What is pulmonary edema? Edema in the pulmonaries, right? So we have fluid in the alveolus, okay? So we have fluid. Instead of pus in there, we have fluid in there, right? And it's not just one alveolus, it's all the alveolus. So they become hypoxic pretty quick, right? So their PO2 starts going down. They're going to start to breathe fast or slow? Fast, because what got triggered? The SNS triggered up, right? And then there's something called a pleural effusion. A pleural effusion is not fluid inside the alveolus, but it's fluid inside the interstitial spaces, right? So we have, let's say here, we got fluid in our interstitial spaces there. And that's going to make it also difficult for PO2 and PCO2 to travel from the alveolus into the capillaries, right? So these are reasons for a respiratory acidosis, right? But what if it's profound? It will then, again, it's a spectrum, right? Eventually, you're going to fall off the edge. You're not going to have enough oxygen to even increase your respiratory rate, right, from your brain. All right, so let's continue the story. So PO2 is going to make its way into the pulmonary capillaries, and then you're going to travel through the pulmonary arteries or veins? Another anatomy question. Pulmonary veins, right? Return blood to the heart, return blood to the left atrium. Your left ventricle is going to pump that blood into the arterial system. in all of our arterial capillaries. So let's click this guy right here. Nope, that's not right. Nope. There we go. All right. So it's going to travel all the way through the arteries, the arterial blood, and then the arterial blood is where we can take a little sample. You say, what are you doing with that? I'll take a sample. And you take a little sample, and that's your ABG, right? On your ABG, you can measure the PO2. What's a normal PO2? 80 to 100, right? And that's the PO2. That's the little tiny 3% that's dissolved in the blood, right? And you can measure the little tiny 3 to 5% of the big 10%. It's a huge, very, very small piece of arterial blood. You can measure the PCO2. What does P stand for? It's the partial pressure of CO2 that made its way into the bloodstream, right? So PCO2 is 40. If at the lungs you didn't deposit the CO2 because you weren't breathing fast enough, right, that CO2 in the alveolus kept going up and up and up. Why does CO2 in the alveolus go up? Because you didn't blow it out, right? Then that's going to then cause your arterial CO2 to also go up, right? So normal ABG has a PO2 of 80 to 100, PCO2 of 35 to 45. And then it's time for the purpose of oxygen. What is oxygen's purpose in life? Keep the cell alive? What does it do? Makes ATP, no. It's used, I guess, technically. It's a, what's the word? It's a good example. It's a poop collector, right? So it's all it does is collect poop, right? And what's the poop it collects? It's hydrogen ions, right? It collects, so during the process of making ATP, you spin hydrogen ions from the interstitial space of the mitochondria into the center space, and via cytochrome systems, all 7 cytochromes, all those fun things, right? And the hydrogen ions spin across that channel, and then the O2 is there. It catches half an O2. An O molecule catches 2 hydrogens and becomes what? H2O, right? That's the whole purpose of oxygen, is just to collect poop, right? Collect hydrogen ions in the cells, right? It collects those, and then I have water, right? And that water needs to make you're not gonna get overloaded with water in this situation, but that water will then combine with CO2, and then it will then be exhaled hopefully in the lungs, right? So let's continue our story here. I think this still works, right? So PO2, that oxygen of 100 is going to make its way into the tissues. The tissues are using that oxygen to make energy, right? So they're going to deplete their oxygen sources, and they need to get refilled. And everything goes high to low, so PO2 100 down to the tissues of 40, and now we can make more energy, right? And then the process of making energy is down in the corner. Cut off just a little bit, but we have our oxygen that comes in, and our oxygen is going to come in, and it's going to bind with hydrogen ions. Where the hydrogen ions come from the glucose breakdown. There's many, many steps in glycolysis and Krebs cycle over here, right? And eventually you're going to be making as you break down that glucose molecule, you end up with 6 CO2s, and then you also end up with 6 waters, right? And the waters were from the collection of hydrogen ions, right? And you also get ATP energy for protein making and more energy processes and all kinds of other fun stuff. But you also get heat, and that's going to be more important when you talk about thyroid issues and Med-Surg 3, right? It's like, why do people with hyperthyroidism with excess cellular processes get so hot? Well, it's because of this. They have more cell processes. Their basal metabolic rate is high, okay? So your tissues take that oxygen, they're going to use it, and they're going to make CO2, and the CO2 needs to leave the tissues, so it's going to go high to low, right? So then what's next? Then we go into the venous system, and then we're back to square one, right? And then we have to exhale it. If you don't exhale it, that CO2 is going to stay behind, right? And you can actually, again, you can measure how much CO2 someone's exhaling in the hospital. You can actually measure, hey, how much are you exhaling? It actually lines up right with your PCO2, 35 to 45, right? So you can say, hey, their end-tidal CO2, how much CO2 they exhaled is 50, 55, 60. They probably have what? Respiratory acidosis, right? So ventilation is the movement of oxygen and CO2. And then we have our alveolus, which is responsible for the transport of O2, CO2 across its membranes into the capillaries. And then we have cell respiration all the way at the bottom that is there where we use the oxygen, right? And we produce CO2, all right? So that's the purpose of all these things. So we're going to talk about oxygen next, I think. And when we talk about oxygen, all right, you have to talk about your favorite, which is what? The O2 hemoglobin dissociation curve, of course, right? It's just as a first or second place to the cell respiration. Okay, so take a break, think about it. All right, so then we'll come back and talk about our O2. All right, so partial pressure of oxygen. So we talked about PCO2, right? PCO2 is exhaled where? CO2 is primarily a respiratory function. You either exhale it or you don't. If you don't, what kind of ABG abnormality will you develop? High PCO2, which is called acidosis, which is what variety? Respiratory acidosis, right? So that was CO2, right? Now we're talking about O2. Are they related? No, they're doing their own thing. They're on two different sides of the equation, right? We talk about cell respiration. All right, so PaO2, there's such thing as PVO2, there's such thing as there's many different O2s out there, right? But we're talking about the arterial oxygen. What's a normal PaO2? 80 to 100, right? So normal is 80 to 100, right? And really, in the grand scheme of things, you're going to really freak out when it's less than 60, right? So yes, 80 to 100 is perfect, but when it's lower than that, it's when do we actually start getting concerned? It's when it's less than 60. Okay, even in the 50s, that's going to be pretty a bad situation. And this all relates to the O2 hemoglobin dissociation curve, right? So what was that all about in physiology that you only dumped all your brain for that one test and developed metabolic alkalosis for? Was when your PO2 is this, your saturation is that, right? When your PO2 is really, really low, your saturation is this. And is your hemoglobin a good guy or a bad guy? Does it like to help out the tissues or not? It loves helping out, right? So it loves to get rid of oxygen when the tissues are in need. And when are the tissues in need? When they are acidotic or they're developing lactic acid, when there's a lot of CO2 is not leaving, is there. When the temperature is super high, it's going to dump O2 like nobody's business, right? So the saturation can be less when you have more when you have more temperature, when you have more CO2 molecules and the pH is low, when the oxygen itself is low there, it's going to give up a lot more oxygen, right? How much oxygen does every hemoglobin have? It has about 4, right? 4 oxygens, right? If each hemoglobin gives up 1 oxygen, what's your O2 saturation? 1 less, yeah, which equals? Don't worry, this is not going to be math for the test. So if you have 4 quarters and you give up 1 quarter, how much less money do you have? Yes. So the O2 saturation only goes down to 75%. Usually every hemoglobin gives up 1 oxygen, right? On average. Okay? So they have 4, every hemoglobin can give up oxygen, and it gives up the oxygen based on pH, temperature, oxygen levels in the tissue itself, and also something called 2,3-DPG, which we'll talk about. All right, so your O2 hemoglobin dissociation curve, when it's normal, when everything's absolutely normal, it's going to give off oxygen at a certain PO2 level, right? When your PO2 is this, it's going to give up this much oxygen. When your PO2 is really, really low, it might give up 2 oxygens, right? So normally, what is our normal PO2 was 80 to 100 over here, right? So this scale right here is our PO2, right? And then the scale going up and down is our hemoglobin saturation, right? So how saturated are hemoglobins? Like in general. So if we average out, how many RBCs do we have? 5 trillion. All right, so close. I think you're more off than 2 to 500. If we say 1 billion to 5 trillion. Either way, so we have a lot of RBCs, and of that average, how many are saturated, right? If certain ones gave off oxygen, the other ones didn't, right? So our saturation at 80 to 100 is about 92 to 100%, right? Our hemoglobin can be 100% saturated when our PO2 is 80 to 100, right? And then what if the PO2 starts dropping? When the PO2 now is not 80 to 100, it's now 70 or 60 or 50 or 40. It's going to give up less oxygen or more oxygen? It's going to the hemoglobin is going to start giving off a lot more oxygen, right? So our O2 saturation is going to start to plummet, right? Remember the previous slide had what normally happens, right? So normally our saturation, our venous side goes down to 70%, and our normal PO2 on our venous side is actually around 40. But we're not going to talk about that. Either way, when your PO2, the rule of thumb is 4, 5, 6, 7, 8, 9. So if you put like 4, 5, 6, 7, 8, 9, just kind of visualize in your head. My PO2 is 60, my SAT's 90%, right? So PO2 is 60 is not a big deal, all right? But that equates to a SAT 90%. Now, if my SAT is 80% on the vital sign machine, that means my PO2 is about 50. Can that differ? Yes, it differs based on these things here. The curve can shift to the right, and actually the PO2 might be a lot less, right? And then PO2 of 40 is not great. That's a SAT of 70%. Okay. So why do I bring this up? Because your PO2 doesn't cap off at 100. Where does PO2 cap off at? 500, right? So your PO2 can be 500. Is that cool? No, that actually causes O2 free radicals, right? And you go to whole wheat, they're going to tell you all about O2 free radicals, right? And what supplements to take. But in real life, what happens is you have O2 free radicals are going to start damaging all the tissues, causing more damage, cause your alveolus to break down and get scarred. Is that good if someone has low oxygen levels? No. So it's not great to give everybody oxygen, right? So how do you know how much is too much? Well, if you look at this table right here, there's a healthy person. If my PO2 is 80, my SAT's 95%, all right? My PO2 is 85, SAT 96%, 97%. That's the PO2 100. What if my PO2 is 110? What about 120, 130, 140? Now our SAT is fine. I say SAT, sorry. My SAT is like 98, 7%, 98%, 99%. SAT's 100% on the monitor. That doesn't tell you how much PO2 is actually dissolved because the hemoglobin only saturates so much, right? So my SATs are 99%, 98%, 97% on the right-hand column there. My PO2 starts climbing, 150, 175, 200, 225, all the way up. And you start getting toxic when your PO2 is more than 100. Right? Normal is 80 to 100, so it's not good to provide oxygen just because, right? You only provide oxygen to maintain a SAT of what? Up to like 95%, right? 80 to 95% is fine. Okay, so when we measure PO2, this 80 to 100, again, that's only 3% of the actual oxygen in the body. The other 97% is where? Is on the hemoglobin molecule. Okay, so when you have that PO2 start climbing, it's going to start causing O2 free radicals, and that's why we just don't give O2 unnecessarily, right? One of the things we give for someone having a heart attack is Mona, right? And Mona is just about 100% dead, right? Just like she died in the 1400s. So the only thing we still do with Mona is aspirin, but O is toxic. You don't provide O unless their saturation starts getting low, right? What is a low SAT? Less than usually 88%. That's usually a problem. But for someone having a heart attack, someone having a stroke, we'll allow 92 to 95%. We'll make sure that they're 92, 95. Okay. What are the advantages of a PO2? So PO2 is an accurate impression of oxygenation because you can calculate a saturation from it, the actual saturation. Because when we talk about the pulse ox, I think on the next slide, the pulse ox doesn't measure anything. It doesn't measure your actual PO2 or your O2 hemoglobin saturation. It uses a roundabout way of kind of figuring out what your O2 saturation might be. This is your actual O2 saturation. And when you do a PO2 on an ABG is very painful, and you have to get a sample, and usually it's done once a day at the most. Sometimes every 4 hours if someone's super sick, but it's, when your saturation drops in somebody, like they're snoring, their saturation drops to 70%, they're fine, they'll bounce right back up, right? But what if you grab the PO2 when they're snoring, right? Or you do the bed bath that uses a lot of oxygen, that could be, it differs by about 9 points. So when your PO2 is like 75, oh shoot, 75, well, it could be 83, it could be 57 or 67, right? So that's the variability with it. Okay, it's not affected by dyshemoglobinemias. What's a dyshemoglobinemia? That's when my hemoglobin is abnormal, right? I have a hemoglobin that does not saturate well, right? I have a carboxy hemoglobin. What's CO? Carbon monoxide, right? So there's no way for us to tell, yeah, it's saturated, but is it saturated with O2 molecules? It might be saturated with carbon monoxide, right? And allows accurate calculation of hemoglobin saturation. So like we said, you can actually calculate the actual hemoglobin saturation is. We'll talk about how pulse ox work on the next slide. All right, what are the disadvantages? It's very painful, right? requires arterial access. You can puncture through the artery, you can cause aneurysms, you can cause the hand to fall off. It's not great. So how do we make sure the hand doesn't fall off? You do this, what's called Allen's test, right? Where you occlude both arteries and both arteries going to the hand. And if you want to do it right now, you can look at your own hand, right? You just hold over the arterial and ulnar pulse right there and squeeze your hand, right? And it's going to start to get pale. Right? See how pale my hand is right there? And I unocclude one of the vessels, right? And the hand just fills back up with blood, right? So that lets you know you have another blood vessel in case one blood vessel it it fails, right? You have poor technique and the blood vessel gets an aneurysm or doesn't work, okay? All right, so there could be collection error. This is more like the RT. The RT doesn't know the right process for this. It's not your job to know that what they do is correct or not, okay? There's a measurement delay, right? So it's intermittent. You can't get a continuous ABG analysis on someone. It's not invented yet. So, but you can get a continuous pulse ox on someone. And pulse ox is an impression of what's going on. It's not the actual ABG results, okay? So again, the O2 hemoglobin dissociation curve. So what is that looking at? It's looking at how much oxygen is being dropped off at the tissues, right? So when the pH is really, really low, the hemoglobin is going to drop off a whole bunch of oxygen, right? When the pH is really, really low, that's an indication there may be build up acids there might be some build up CO2 there. They're going to drop off a whole bunch of oxygen. Same thing with temperature, right? So 2,3-DPG is really the enzyme that really governs like 80% of the activity for O2 affinity. It's really there to offload oxygen, right? The more 2,3-DPG you have, the more stinky it gets, right? And the less you love the hemoglobin, the more you love to go off to the tissues and oxygenate them, right? So that's usually that's the largest determinant of our O2 movement, okay? And again, hemoglobin is never empty. It doesn't just drop off 4 molecules. It usually drops off 1, right? And every trillion or so that hits that tissue are going to drop off 1 or maybe not at all because the tissue might be saturated just fine. All right, so the tissue PO2 might be fine.
What does the 2,3-DPG do?
2,3-DPG is what's responsible for O2 leaving the hemoglobin. It's a enzyme protein that's going to offload oxygen. The more 2,3-DPG you have, the more oxygen that will leave hemoglobin. All right, so saturation of oxygen, so SpO2, so not SaO2, but SP, P stand for our pulse oximetry, right? So what's some great stuff about it? It's real-time monitoring. It doesn't hurt to put a pulse ox on someone. You can buy it on Amazon, right? It requires no special expertise. Everybody was an expert during COVID about what their saturation was, right? So everybody had a little pulse oximetry, okay? So it's a way to approximate what your oxygen level might be, okay? So also one thing in the hospital setting, if you got a waveform attached to it, it's pretty nice. It tells you a lot of great information. It can tell you if someone is hypotensive or is vasodilated or vasoconstricted. It can tell you if they have aortic valve stenosis or aortic valve regurg just based on the pulse oximetry waveform. So it gives you a lot of information. People's like, oh, that's just nothing. That just tells you if it's accurate or not. No, it actually gives you great information about the cardiovascular status. Okay. Disadvantages. What are some bad stuff? It's not a direct measurement of sat, right? To get an actual saturation, you have to draw PO2 and use fancy formulas to calculate what a saturation is. This is all they did is they took a bunch of guys in the 50s that are, I think it's the Vietnam War, not Vietnam, the Korean War, right? Everybody knows their history, right? So in the 50s, they took after the Korean War, they took a whole bunch of male recruits, right? And they said, hey, after you eat, let's measure your saturation. And they compared it to their PO2, and they said, this is the table of saturations for normal humans. Don't worry about females. There are white males, so don't worry about black people. Don't worry about these things. Don't worry about those things. This is your O2 saturation, and it's a table that's loaded into every monitor, and it just compares that. It says, hey, if you absorb this much light from this side to this side, that equals this saturation. It doesn't actually measure your saturation. It just measures light absorption, and it compares it to a table of 50s Army men, and says, oh, this is your saturation. Look at that. All right, so it's not entirely accurate. So you have to think about that as well. I think it even says in African Americans, it's off by about 2%. Right, and that's not great because like Medicare will give you oxygen if your saturation is X, Y, or Z. It's like, no, you don't need oxygens, but I do. I don't feel great, right? So they won't give it to you because they have because that's what they base off the saturation instead of the ABG. Okay, it doesn't reflect hyperoxic patients. Remember, it caps out at 100%. Right, once your hemoglobin is saturated 100%, the other PO2 is going to spill into the bloodstream, and it can go all the way to 500. Right. and you get O2 toxic from it. Okay, and then no absolute calibration. There's a few different tricks out there. There's like, again, the waveform. You have a waveform. That means it's actually, it might be accurate. There's little stars right here, little Yelp reviews. You can say, oh yeah, 5 out of 5 stars. So you got a good pulse ox. Another thing they might look at is like, hey, the heart rate matches the heart rate on the pulse ox. So that might be accurate. Okay. So it's unreliable in patients that are really, really hypoxic. So it's not great in hyperoxic, not great in hypoxic. As long as it's only great when you can actually, the light can actually make its way from one side of the tissue to the other side, right? So that's a saturation like less than 85%, less than 75%, definitely not accurate. Okay, poor perfusion. Well, I'm not getting perfusion of my fingers, so it's like, oh, your saturation is this. Like, really? Is that really my saturation, or is it actually different, right? There's conditions where people have like Raynaud syndrome, where they have lack of flow to their fingers. There's other things out there. Just cold fingers can make our saturation inaccurate. Nail polish, remember this is light that's being absorbed, right? So it's saying, did you absorb this much light, right? Usually hemoglobin, when it's saturated, absorbs this much light. But if you have nail polish, and you have red nail polish, and you have red light, it's going to be off. Okay? So blue-black actually drops it the most. And then confused patients, right? It can't be moving around. It can't be artifact. It has to be patients that are relatively still, right? Sometimes those patients will put on the toe. That way they can move the toe as much as their hands. And then light itself, right? So if other light gets in here, right, it's going to disrupt the signal, and you're not going to get a great waveform, a great value. All right. So again, this came out in like the late 70s, the saturation. So like before that, they said, are they hypoxic? Yes, they're good, right? So before 1980, and like you go to surgery, like a 6-hour surgery, it's like the anesthesiologist is like, are they blue? No? Okay, continue, right? There was really no, like it's amazing about what we had, what we have now. Okay, so normal, like healthy people without oxygen, 95 to 100%. That's perfect, right? That's right now. You probably won't have an O2 deficit, because if your SpO2, your saturation is 90%. What is your PO2? Saturation is 90%. 60. Remember 4, 5, 6, 7, 8, 9, right? So 40, 50, 60 is equal to 70, 80, 90, right? 90% sat, PO2 60. Probably not great, right? So if we have an MI or a stroke, right? MI or CVA will get you up to 95%. Why not 96, 97, 98? Because now you can start getting hyperoxic. And when tissue is trying to repair itself, it doesn't need O2 free radicals trying to tell them what to do. It's going to cause worsening recovery. Okay? And then what else? We have COPD, ARDS, that's acute respiratory distress syndrome. You'll learn about that in Med-Surg 3. It's the same thing with vented patients. Usually just like 80 to 92. That's perfect. We don't want to overdo it, because then we're going to impair their healing. Okay? Hypoxic patients, you got a SAT of less than 88%, you probably need to have oxygen in place. You're severely hypoxic, and your SAT's less than 85%, you can't trust if you're less than 70%. Okay? So that's the idea with pulse oxes. All right, so the last thing with oxygen, remember oxygen goes right here at the end of the cycle, right? Oxygen is only used at the very, very end to take up some hydrogen ions that were accumulating, and it attaches there, a little half molecule of oxygen, and then now you get H2O, right? So we get H2O as that's what oxygen does, okay? What else do you get out of for, what's the word, as waste products, are CO2, right? So CO2, there's many different spots along the pathway here where CO2 gets carved off. The glucose molecule gets carved off the lipid molecule, or gets carved off the amino acid, and you get CO2 as a result, right? And then you have to exhale that CO2. Otherwise, it builds up and you develop what? Respiratory acidosis, right? So CO2 is a waste product, water is a waste product. The water came from the oxygen story, right? So this all relates to cell respiration. So all these steps here, what you learned in physiology was to ultimately make ATP, right? You get ATP out of this, and that ATP is then used for many, many other processes, cell processes, right? So ATP gets made, we get CO2 and water as a byproduct, and also get some heat as well, okay? If you have increased basal metabolic rate, that's going to cause you to be a lot more hot than usual, Okay, not like good looking hot, but hot, hot. All right, so it requires oxygen. You need oxygen for this whole thing to happen. Otherwise, these acid molecules are gonna develop up, and then that's gonna denature the proteins here, the mitochondria. So the mitochondria are closed for business. They know that's a problem when you have no oxygen or low oxygen. So they shut down when you have no oxygen. And now you still have this piece up here, glycolysis to function, so you can still make some energy. And you go into debt. You start making lactic acid, right, when you have a low oxygen state. When else would you make lactic acid? What else is a reason why O2 would not make it to the cells? Because you didn't breathe it in, or your blood pressure was low, right? That'd be a good reason, right? The cells don't care. They just say, "I'm not getting oxygen," right? Well, it says, "Well, okay, the Amazon truck, he got in a car accident. I don't care. I don't have my scale, right? I need to have this delivered, right? Or it could be low on scales, right? It could be one of the two, either low blood pressure or low oxygen. That's usually one of the only two reasons why that happens. And that's going to, again, that's a mantra that can take you very, very far. If someone has hypotension, you're going to get lactic acid. Someone has CHF, right? Their heart cannot pump blood, right? You're going to get a lactic acid buildup because you're not pumping blood to the tissues, right? So that's lactic acid will form when there's no oxygen being delivered. Okay, but what if everything's working and we need to, we run out of glucose? What do? When do you run out of glucose? Usually 4 hours after you eat, you run out of glucose, right? And then you have to use other sources. What other sources do you have available to you? Well, first of all, you have glucose sources, right? Where do those glucose sources come from? Well, when you eat, your body's like, "I'm saving you for later," right? It's like, it's like when you go out to try to lose weight, you take half of it into a doggy bag. It's kind of almost the same thing, right? You use some of the glucose now, and the rest isn't going in a doggy bag. Where does the doggy bag go? In one of the 500 processes of the liver, it's going to go into be formed into glycogen, right? And also the muscles do this too. All right, so the muscles are going to form glycogen. The liver is going to form glycogen for when you don't have glucose available. That's our first source, right? So we take the glycogen stores and we just pop it, we convert it into glucose. That's another function of the liver. It makes glycogen, it breaks down glycogen, right? Muscles do this as well. So now we have glucose, right? And now we go through our normal process. We have energy and ATP to do our stuff, right? And that's called glycogenolysis, right? Or glycogenolysis. So lysis means what? Breakdown of. So we're breaking down what? Glycogen, right? Then another source of energy is lipolysis. We're breaking down what? Lipids and fat, right? So the fat, so we used to be hunter-gatherers and used to not have, Krispy Kreme and McDonald's and French fries and things that have a whole bunch of fat in it, right? Our diet didn't have a lot of fat in it, so glycogen store is really all we needed. We didn't need to store fat for later, but now America does store a lot of fat for later. So we have a lot of fat to use, right? That fat gets stored as free fatty acids, right? And fatty acids have three fatty acids and a glycerol molecule, right? So if we were to break it down, right? Our fats say, "Hey, it's your time to shine," right? They use their glycogen stores, and now it's time to use our fat stores, right? So now we break down all that fat that's stored away, and then we lyse it, and we convert it into free fatty acids and glycerol in the liver. And it's going to then do all that, break it down into things we can use, right? So the glycerol enters right here, and then we get some ATP out of it. The fatty acids enter right there, and we get some ATP out of it, right? So fats are an important energy storage piece, okay? The other thing that we do from breaking down fats and free fatty acids is make ketones, right? So we talk about diabetic ketoacidosis. It's usually because we ran out of glucose, right? Or we think we ran out of glucose. We really didn't. It was just we didn't have any way to put the glucose into the cells. So the cells are starving. So where's a lot of glucose at? You need to start breaking down fats. So you start breaking down fats, so you start making ketones. So now you have ketoacidosis.
Do people get like ketoacidosis from doing that? What is that?
Yeah, the ketone diet or the keto diet. That's the whole purpose of it. You have a very extremely low carb, it's an extremely low glucose diet. So then your body's going to shift over to ketosis, where you're making ketones. Okay, and you're forcing yourself to break down fats. All right, and our last source is proteins. All right, we break down proteins as our last source. That's probably not a great idea. Proteins that we mentioned before were good. Hemoglobin, actin, myosin, immunoglobulins. We have all kinds of things and even all these enzymes in this whole cycle are proteins, right? So we probably don't want to break down proteins. That's what we only have one hormone that breaks down that protein, right? So we have that ability, if we needed to, if we ran out of fats, ran out of glucose storage, we can break down proteins, right? And proteins are made of amino acids. How many amino acids? 50 to 5,000 amino acids, right? And this cycle right here gives you about 12 ATP. So 12 times 5,000 is a lot of freaking ATP, right? Whereas glucose only gives you about 36 ATP, right? So 36 compared to 12 times 5,000, which is what? A lot, right? So anyways, we have a lot, like 30,000 plus ATP just from breaking down one little tiny protein, okay? So yeah, so that's the whole purpose of these things. The reason why I'm spending time on this is because when we talk about diabetes, it's the same thing. We're going to be breaking down these things. We're going to talk about glycogenolysis and the hormone responsible for it, and the hormone responsible for proteolysis to break down proteins, okay? Oh, those are the things you have to know for the test, the different processes for cell respiration. All right, so metabolics. We're shifting gears from respiratory stuff, right? Remember, O2 is not involved in your interpretation of respiratory acidosis, respiratory alkalosis. It's a way to figure out the cause of symptoms, metabolic or respiratory for that matter. Now we're going to shift gears, talk about metabolic alkalosis and acidosis. Remember we talked about the pyloric sphincter. The pyloric sphincter is the magic piece right here, right there between the stomach and the duodenum, right? It's right up there, right? This is the duodenum right here. Okay, so the pyloric sphincter is closed, and it only opens when it's time for a gastric bolus to make its way into the duodenum, right? And then that gastric bolus has what in it? Has food and fire, has hydrochloric acid, right? And that's going to start eating away at the tissues because our stomach's specially designed to tolerate hydrochloric acid. So how do we neutralize it? Bicarb. So our bicarb here is going to neutralize the hydrochloric acid. The pancreas squirts out bicarb, right? It has many other functions, but it's going to squirt out bicarb to neutralize it. What if it's squirting it out and you don't have time to reabsorb it in the small bowel? Now you have, that's like diarrhea, right? Or you have an ileostomy right here. Let's do this one. You have an ileostomy, let's do this guy. We have an ileostomy there or a colostomy there, right? We have increased output via our colostomy, ileostomy. We have diarrhea. Now we're squirting out bicarb, right? So that's going to be a situation where you get metabolic what? We lose bicarb, we get metabolic acidosis, right? So that's if hydrochloric acid made its way past the pyloric sphincter. What if it didn't? What if you did what? You vomited it up. All the hydrochloric acid produced by the stomach usually gets reabsorbed right there, right, in the duodenum ileum. But what if you can't reabsorb it because you threw it up? You get what? Alkalosis, right? So you get metabolic alkalosis when you throw up too much, right? What's another way, a fancy way of saying that with extra steps is you have an NG tube to too much suction, right? So you have an NG tube sitting right in the stomach right here. So you got an NG tube sitting right there, and then you're pulling out all kinds of stuff. How much output you get? I got 600 overnight. So well, that's way too much, right? You should not be getting that much fluid out of the stomach. Okay. So again, when you drop acid, that hydrochloric acid or whatever acid it is, the hydrogen ions get dispersed, right? And we can measure how much it disperses it. If it disperses a lot, then it's really, really acidotic, right? Its power of hydrogen, the amount of hydrogen ions it spurts out are a lot, right? And that's like hydrochloric acid. Its pH is around 2 to 3, right? So it spurts out a lot more acid compared to like citric acid. Okay, so that's the idea with these free hydrogen ions are floating around, and we need to neutralize them. All right, we neutralize them with bicarb. That's in the serum. But when we talk about the GI tract, then it's a little bit easier to visualize, right? It's easier to visualize diarrhea and visualize vomit, I guess, right? So you can think about, oh, I'm throwing up hydrochloric acid, or I'm pooping out bicarb. Okay, so metabolic alkalosis. How do you get alkalosis? Well, we talked about the GI part, right? We have excess bicarb because we threw up the hydrochloric acid, right? You took away the hydrochloric acid, right? So we take away acid over here, our scale is going to get more alkalotic. Okay, and then, so that's vomiting, NG tube with excess suction. That's an iatrogenic reason. What does iatrogenic mean again? It means oops, right? Yes, it would happen in the hospital, but it was your fault. Okay, so hospital acquired iatrogenic reason for, and that's what we're trained to do to prevent that from happening, right? All right, so net gain of bicarb. Why would you gain bicarb? Well, what if you have potassium wasting diuretics, right? And we'll talk about how this happens. But your kidneys are getting rid of potassium, and then you're getting rid of a whole bunch of fluid, and just overall, if you get rid of fluid and your bicarb doesn't change, you're going to get more bicarb per fluid, right? You're going to get more concentrated bicarb. That's called a contraction alkalosis. Because you lost all this fluid, you get alkalotic. This is it's like peeing out fluid, peeing out too much, right? And then intake of antacids. So you intake some Tums or some Alka-Seltzer. That's you're going to gain some bicarb, and that bicarb is going to make its way into the GI tract, and you're going to absorb that Tums or whatever in your duodenum or ileum, all right? And you're going to gain too much bicarb just by ingesting it, okay? Also, in the hospital setting, we start bicarb drips on patients via IV, a bicarb infusion. It's usually for kidney failure patients or patients that might be going into kidney failure. You'll see this bicarb drip infusing. And if that goes unchecked, then that could lead to metabolic alkalosis. So how do we make sure it does not go unchecked? Check it. Very good answer. How do you check it? Look at the labs. What labs? You could do the ABG, but they get labs done every morning. It's like, why are you going to poke me again? They already drew my labs this morning. It's like, you're right, sir. Let me look at your labs. What are you going to look at? Chem panel. What on the chem panel? You could look at potassium. What else could you look at? The CO2 in the chem panel is actually your bicarb in disguise, right? It's under witness protection, right? So that is your bicarb on the chemistry, all right? So you look at that bicarb in the chemistry. That bicarb is more than what would be a reason for metabolic alkalosis. On the chemistry, the bicarb would be greater than what? It's for it to be metabolic alkalosis. 745, 735 is pH, right? pH is not measured on your chemistry. What's measured on the chemistry? The bicarb levels. 4 or 5, that's your CO2, not your bicarb. Greater than 26, right? So you can, if you double click, you go to clinical, you double click on the values there, it says 22 to 26. You look at the CO2 and the chemistry, right? It's just hiding in plain sight. Okay, so that's a way to see, well, do we still need this bicarb infusion? Look, their bicarb is 32, right? It's our problem if we don't let somebody know about it. Okay, all right, so that's metabolic alkalosis, and those are the causes of metabolic alkalosis, right? What about metabolic acidosis? Okay, so acidosis is, again, things that will kill you, right? So you're gaining acids, all right? Acids in the form of like acetylsalicylic acid or ethylene glycol antifreeze, or there's some TB meds and other things out there that you might ingest. But the things we talk about this semester are ketoacidosis, K, right? We talked about L, lactate, we'll talk about a little bit. And then uremia or renal failure can put you into a gain of acids. You're literally adding acids to the equation, right? And when you add acids to the equation, what other number goes down? The bicarb, because the bicarb is getting used up. It's binding to those acids, okay? So we're building up acids in renal failure because we're not peeing them out. They're staying behind, right? And now our bicarb is getting utilized, right? And also hyperkalemia is an important reason, and we'll talk about the reason why, okay? And then GI causes. So we have excess diarrhea, and that's going to cause a metabolic what? Metabolic acidosis, right? Metabolic acidosis comes out there you go. All right, and what is diarrhea like? So that's called, how do you assess, oh, they got diarrhea. How do you know someone has diarrhea? And they can show you it. They can, what else we tell them? Say, hey, how many times have you gone already? Greater than 3 times, right? And if they have a little fancy toilet, like, I don't know if Kohler makes this brand, but they're missing out on the opportunity to weigh a stool, right? So it's more than 200 grams per day, right? Say, hey, you got diarrhea, right? Get a little phone alert. Oh, thanks, right? So that's if more than 200 cc's a day. Some patients have rectal tubes that measure the amount of diarrhea, right? So they got more than 200 cc's, that's considered diarrhea, okay? So things that will kill you are metabolic acidosis or alkalosis. Metabolic acidosis.